Welcome to this explainer. Before we dive in, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Today we're exploring exactly how hospitals get paid for inpatient care. It's this fascinating, heavily regulated, and honestly, kind of hidden world of coding and clinical documentation that literally drives the entire healthcare revenue cycle.
Now, you might think hospitals bill like a mechanic, charging per pill, per bandage, or per hour of nursing care. But for inpatients, it's actually all about a single flat rate payment bucket. It is definitely not an itemized receipt. Instead, it's a meticulously calculated system designed to match the clinical complexity of each specific patient.
Okay, let's dive right into the foundational concept here, the MS-DRG. That stands for Medicare Severity Diagnosis Related Group. This is the absolutely crucial code that dictates exactly how much Medicare, and honestly most commercial payers, reimburse a hospital for a patient's stay. Think of it like a giant sorting hat, grouping thousands of unique patient scenarios into categories based on clinical and resource similarity, all to result in one fixed payment.
Here is our roadmap for this explainer. We're going to start with how hospitals get paid, peek inside the MS-DRG architecture, examine the real power of CCs and MCCs, look at present on admission rules, and finally, uncover the vital role of CDI.
All right, let's kick things off with Section 1, how hospitals get paid.
So, accurate medical coding isn't just administrative paperwork, right? It is the absolute core driver of a hospital's financial reimbursement and their quality scores. The word prospective in the inpatient prospective payment system means the payment amount is largely fixed before the patient is even discharged. It all hinges entirely on getting the clinical documentation perfectly aligned with the coding. Moving right along to Section 2, inside the MS-DRG architecture. It's really fascinating how the system mathematically organizes thousands of different conditions into such a clean framework. Every patient case is first sorted into a major diagnostic category, or MDC. There are 25 of these, and it corresponds to major organ systems, like the circulatory or respiratory system. From there, it's split into a medical or surgical partition. Basically, did the patient require a significant operating room procedure? And finally, that base grouping is adjusted based on the overall severity of the illness. So the crucial point here is that specialized software, which we call a grouper, follows these exact steps. It identifies the principal diagnosis, checks for added complexities, looks for major procedures, adjusts for things like the patient's age and discharge disposition, and ultimately turns all those complex clinical inputs into one of about 750 final payment groups. It's a powerful logic engine calculating the precise value of the care provided. Let's jump to Section 3, the power of CCs and MCCs. Let's look at how specific words written by a doctor can dramatically alter that final payment. A massive distinction in coding is the difference between why a patient walked in the door versus what the doctors actually found. For example, a patient comes in for chest pain. That's the primary reason for admission. But the hospital is paid based on the principal diagnosis established after study, like an acute myocardial infarction. If the final documentation just vaguely says chest pain, the hospital is going to be vastly underpaid for treating a literal heart attack. And welcome to the DRG triplet. Almost every MS-DRG comes in 3 tiers. Let's say the base issue is heart failure. If the chart just says heart failure without any complications, the hospital gets the lowest payment. If they document a complication and comorbidity, a CC, payment goes up. But adding a major complication and comorbidity, or MCC, like documenting that the patient was also in shock, that bumps the hospital to the highest payment tier. A single, highly specific phrase radically changes the hospital's reimbursement, sometimes by tens of thousands of dollars. Okay, Section 4, Present on Admission, or POA for short. But here's a bit of a narrative twist. What if a major complication happens after the patient is already in a hospital bed? Well, Medicare requires a present on admission flag for all diagnoses to enforce quality control and track hospital-acquired conditions. Y means it was there when they walked in, and means it wasn't. Let's see how this builds into real-world financial consequences for the facility. Imagine a patient is admitted, and the grouper calculates a high relative weight payment, say 1.9015 for severe sepsis. But let's say the patient develops a deep vein thrombosis, which is a major complication, during their stay. Because it's flagged N for not present on admission, it's considered a hospital-acquired condition. The system literally ignores it for payment purposes. This means the payment weight drops significantly, and the hospital just has to absorb the financial penalty for that added care.
Which brings us to our final part, Section 5, the role of CDI. So, how do hospitals prevent vague documentation from ruining their revenue and their compliance? How do they ensure they actually get credit for the complexity of the care they deliver? Well, clinical documentation improvement, or CDI teams, are basically the detectives who query doctors for clarity when the chart is ambiguous. But it's a real tightrope walk. They must use strictly non-leading questions to avoid unethical upcoding. You absolutely cannot ask a leading question like, do you agree the patient has septic shock, just to trigger an MCC? You have to ask a compliant, non-leading question such as, based on these lab values, can you clarify if the anemia is acute or chronic?
Every single query becomes part of a highly regulated workflow. It's not just a casual chat in the hallway, guys. It must be traceable, it must be auditable, and reportable. This ensures that the final build codes perfectly match the true clinical picture of the patient's severity. This ethical optimization protects revenue integrity while strictly following Medicare rules.
We've seen how the difference between vague notes and precise terminology can mean absolutely everything to a hospital's survival. Ultimately, clinical documentation isn't just about financial metrics or kicking boxes for the MS-DRG grouper. It's the permanent record of a patient's health journey. So the provocative question you have to ask yourself is, how will you ensure your charts reflect the true complexity and quality of the care provided? Thanks for joining me. And remember, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.